Hello everyone, welcome back once again. Today we are going to look at constipation as our topic about the GIT disorders. So we find that constipation is one of the disorders that can affect the GIT or the gastrointestinal system. So we see that defining constipation is a condition characterized by hardened feces and difficulty emptying the bowel. Abnormally frequent and difficult passage of feces. We see that the symptoms, it is a symptom, not a disease. So disorder of movement through the colon and or the rectum is what we call constipation. Can be caused by a variety of diseases or drugs. What are some of the causes of constipation? If you have issues with diet, if you're not taking dietary products, or if you're not taking roughage in your diet, yeah, or you have inadequate fluid intake. Some people take 2 days without taking water, some people take the whole day without taking, or maybe in the whole day you are taking like 5 mils of water. It's unhealthy. You may end up getting constipation. In young children, we can find that concentrated feeds, the different feeds on market that we are giving our children, and some of them can be concentrated, and as a result may bring about constipation in them. Lack of exercise. It's good for you to exercise, okay? So you see that exercising improves our muscle activity and blood circulation. That's it can affect majorly those patients who are bedridden because they're not walking, they're not doing any exercise, they're not doing anything. And also you can also have the elderly, yeah. So you find that the activity of the elderly, the activeness of the elderly is quite reduced, and it can affect psychological. You can have stress, anxiety also can bring about constipation. You can have certain drugs or some drugs, their adverse drug reactions can be constipation. Yeah. Narcotic analgesic, we have anticholinergics, antacids can be some of the causes, and then we have calcium channel blockers, we have anti-Parkinson's drugs, you can have opioids, you can have anticholinergics, you can have antacids, you can have NSAIDs, and antidiarrheal drugs. When you're giving drugs for management of diarrhea, you find that if the person uses them for a longer time, they end up getting constipation. So what are some of the metabolic disorders that may predispose somebody to constipation? We have hypothyroidism and then diabetes mellitus. So how do we classify constipation? So you can classify constipation as slow transit constipation, whereby we have a chronic intania characterized by a prolonged delay in transit of stool through the colon due to the neuromuscular dysfunction of the colon. You can also have what we call functional defecation disorder or pelvic floor dysfunction, a difficulty or inability to expel stool from the anal rectum due to the neuromuscular dysfunction of the defecation unit. You can have constipation predominant irritable bowel syndrome, where we have a third subtype of constipation associated with the abdominal discomfort. Some other causes may be post-operative effect. Those patients that have just been operated, they can also present with constipation in a few days. So what is the treatment for constipation? So we need to first educate our patients or have a patient education and behavior modification. So we saw that when you're not eating some of the dietary recommended diets, a patient can end up presenting with constipation. So we have to encourage our patient to have adequate fluid intake and fiber intake. We also advise for chronic motor activity, maybe exercises, highest in the morning after eating. We can also have what we call function modification disorder, whereby there is biofeedback, sensory training can be done, relaxation exercises can be done, and then suppository programs can also be given to the patient. Drugs for constipation, we have laxatives, and then we have bulking agents. Those bulking agents contain fiber in them. We have osmotic stimulant, and then lubricating agents, and then the fecal softeners or softening agents. Whereby under that we have what we call laxative effect, or they have that laxative effect that enables to soften the stool. We can also have what we call the cathetic effects or the fluid stool. So there are three generation mechanisms of action for the different things that or medications that we use to give to our patients that are suffering or are having constipation. We have what we call hydrophilic or osmotic properties. We see that those ones promote retention of water in the colon and increase bulk and soften or softness and facilitate transit. We see that it also acts on the colonic mucosa to decrease absorption of water. They will act on the colonic mucosa to decrease absorption of water. Will also increase intestinal propulsive motility and then decreasing absorption of fluid secondary to the decrease the transit time. Bulk forming laxatives, what are they? We say that the bulk forming laxatives relieve constipation by increasing the fecal mass, which stimulates peristalsis. They contain a higher fiber and may absorb water to increase bulk. Distends bowel to initiate reflex bowel activity. Caution has to be put on whereby we need to counsel your patient. Adequate fluid intake must be maintained to avoid intestinal obstruction. Your patient can have obstruction and that can be very dangerous. Some of the examples for the bulk forming laxatives, when you're giving them these medications, make sure they're always taking water. We have methyl or fluids, yeah, not necessarily water, but fluids have to be taken in. And we know a number of fluids that your patients can take. We have methyl cellulose as one of the bulk forming laxative. What are some of the side effects that your patient may present when they are taking these specific medications for constipation? They can have flatulence, abdominal distension, gastrointestinal obstruction, and then hypersensitivity can be reported. What are the stimulant laxatives that you may have? So the mechanism of action is based on the stimulation of the intestinal motility and mucosal electrolyte secretion. Most times constipation, all the time constipation takes place or happens when there is decreased intestinal motility. When there is decreased intestinal motility, that's why we see that there is a high chance of your patient experiencing obstruction. And once obstruction is experienced, that is very dangerous. Stimulant laxative increase intestinal motility and often causes abdominal cramps to your patients. So some of the natural plants that can be used as a stimulant, we have the senna plant, the palamtum plants, the aloe vera species can also work as the natural stimulant laxative. But the synthetic compounds under this specific class is where we have bisacodyl, and those who have experienced this constipation must have interacted with bisacodyl most of the time. So we see that these medications are powerful stimulants, and we have others apart from those. One of it is what we call castor oil, but Use castor oil with caution. Do not use on pregnant mothers because it has a side effect of contraction. Okay, and because of that side effect may end up bringing up a miscarriage for mothers who are expecting. We may also need cholesterol suppositories. You may need them to enable rectal stimulation, or it may work as a rectal stimulant. Bisacodyl has a half-life of 8 hours. So half-life enables you to know when to give the next dose. So by knowing the 8 hours, you could be in position now to know when do you give the next dose. We have what we call the Dantron, only for constipation in terminally ill patients of all ages. When your patient is terminally ill and presenting with constipation is when you can use it. Glycerol, like we have said, you use the glycerol suppositories, and you may need the Senna natural plant product. We can also have what you call the fecal softeners. These fecal softeners will promote more water and fat in the stool, lubricates the fecal material and intestinal walls. It is non-absorbed lubricant which enhances flow. Examples: stool softener, and then we have lubricants. So mineral oil as your lubricant. You can also have castor oil as a lubricant. You can also have glycerol and other liquid paraffin. Osmotic laxatives or saline agents. Osmotic, we see that we are focusing on increasing the amount of water in the large intestine, either by drawing the fluid from the blood into the bowel or by retaining the fluid they have administered with. So we see that when the fluid is retained in the bowel, it will promote the stool to be softened. So we see that lactulose is a semi-synthetic disaccharide which is not absorbed from the gastrointestinal tract. It produces osmotic diarrhea of low fecal pH. So we have cases where they may have lactose intolerance. So when those patients that have lactose intolerance, for them they will present with diarrhea. So we see that they have a problem in digesting milk, and we know that milk has lactose, meaning they don't have the enzyme that will break the lactose into its smaller sugar components. So you see that you may need that. We have glycerin as another compound, we have sorbitol as the other, and then the macrogols as others. So this marks the end of our lecture on constipation. The next time we are meeting, we are looking at vomiting, or we can call it emesis. Thank you so much all for listening to me. Kindly subscribe to this channel so that you get more experience like this and you are able to appreciate the different conditions that we may have. Thank you so much. I wish you a good time, and stay tuned to Grapham Academy. Share this content with the various people that you are interacting with in your discussion groups, in your class groups, and so many others.